So my talk would be on clinical relevance and interpretation of full field ERG, and I'll basically be showing you clinical examples. Please stop me if you have any doubts in between. I don't have any financial interest. Coming to interpretation of full field ERG. So there are basic responses as per the ICIF protocol. I will stick to the well-known nomenclature so that it is easier for you to understand. I'll be using that throughout my lecture. So how does a normal ERG look like? First, I'll show you a scotopic 24 decibel single flash, which is the isolated rod response, and this is a very good positive B wave that you see. So this is a normal scotopic 24 decibel. This is how it looks like. And coming to the maximal combined response, we have an initial negative A wave and a positive B wave. In that, certain parameters are important. The A wave amplitude, it's measured from the baseline to the trough. That is the A wave amplitude. And then we have what is called the B wave amplitude, which is measured from the trough of the A wave, goes right up to the peak of the B wave. This is very, very important. And we have something called implicit time, which is from the baseline to the peak of the B wave. Then we have a series of small wavelets which are filtered out by the ERG machine on the ascending limb of the B wave of the maximal combined response, and these are the oscillatory potentials. And then after a period of light adaptation, we have the pure cone response, which is a photopic 0 decibel. It too is a mirror image of the maximal combined response, which is photopic 0 decibel, but it's smaller, a negative A wave followed by a B wave. So then we have the flicker ERG, which is the 30 hertz flicker. Most of the machines give either a black arrowhead like this or black lines. So on a cursory examination itself, if your peaks are in front of these black arrowheads or black lines, it means that the latency is very good, and hence it's more or less a normal 30 hertz flicker. So that's one way you can rapidly see whether it's normal or abnormal ERG. So I'll quickly go on to the clinical relevance of full field ERG. Now, why do we need full field ERG? To answer this gentleman's question, basically you must understand that full field ERG is a global retinal response, okay? But still the individual ERG components have origins in different retinal layers, and hence if we accurately analyze which component is involved, we may be able to localize the site of retinal dysfunction. For instance, the first arm of the global ERG is the scotopic 24 decibel, isn't it? And in that, the B wave basically represents rod system sensitivity, and hence if you have a flat scotopic 24 decibel, it means that the rods of your patient are gone. Is that clear? Next, we come to the maximal combined response. I told you there's a negative A wave initially, okay? So the first 10 to 12 milliseconds of the slope of the negative A wave basically relates to photoreceptor hyperpolarization, and hence if the A wave is knocked out, that means your patient's photoreceptors are knocked out as well. Okay, and then we come to the B wave of the maximal ERG. You must understand that B wave is a very good indicator of the post-phototransduction process. So any problem which is post-photoreceptor in origin, especially reflecting the rod-on bipolar cell problem, so that in that case the B wave of the maximal combined response will be flat or lesser than the A wave, and you get what is called the negative ERG. I'll be showing you clinical examples. And basically after the period of light adaptation, what you get, the 30 hertz flicker and the photopic single flash. They are all of midretinal origin, but basically reflect cone system problems. So I have many people, even ophthalmologists and retinologists, who continuously ask me, this patient has RP, retinitis pigmentosa. It is so clinically obvious. Why do you want to order a full field ERG? It's a waste of the patient's time and money. I will show you some reasons why I feel it is important that you do ERG, full field ERG, even in certain disorders which are clinically obvious like RP, because there is a poor correlation between the fundus appearance and functionality. And it's also important to understand that full field ERG is the only test that we have today which will reliably distinguish between rod and cone dysfunctions. Coming to RP, all of you are aware that in RP, that's basically a flat initial responses in ERG. It's a rod cone pattern. Basically in RP, there is a dysfunction at the photoreceptor level, and hence the rod specific B wave, that is a scotopic 24 decibel is flat. At the same time, the A wave is extinguished and the B wave shows a concomitant reduction of the maximal combined response, and the cone responses are variably affected depending on the severity of RP. And hence in RP, the ERG, the full field ERG is basically a rod cone pattern of ERG. So I will show you. This is the normal ERG that we have. This is the scotopic 24 decibel, the first response, and you see that it is quite flat. And this is the maximal combined response. You see the normal ERG, you have a negative A wave and a positive B wave. Again in RP it is flat, and the oscillator potentials also can't be made out. And this is the photopic 0 decibel. In this patient there's an extensive cone dysfunction as well. So this is also flat, and the 30 hertz flicker, this is a normal 30 hertz flicker, and this is a flat one in RP. Also, interestingly, ERG can tell us about the inheritance pattern in RP. For instance, in X-linked recessive RP, which is a severe type of RP, ERG is severely reduced or attenuated even at an early age, in contrast to autosomal dominant RP, where basically there is a later onset and slower progression of RP. And in restricted disease, you have amplitude reduction without implicit time shifts. Okay, this is another example of rod cone dystrophy, and you see that the visual acuity is 6.6 in this patient, but both the scotopic and the photopic responses are attenuated. There is a good pattern ERG, because pattern ERG, if you recall Dr. Shetty's presentation, comes from the macula, and which it's good, which corroborates with a visual acuity of 6.6. Whereas if you see this patient has 6.9, a relatively good visual acuity, but again the rod systems are gone, but the cones show some amount of activity, but the PERG is also quite flat. This is the normal pattern ERG that I'm showing down. These are all for normal patients. And RP in serial ERGs have also got a small role to play in certain types of syndromic RP like Refson's disease, in which they may demonstrate the arrest of decline by regular plasmapheresis and low phytanic acid diet. This is another interesting condition, enhanced S-cone syndrome, which clinically presents with night blindness or maculopathy, and it looks very similar to RP, except that it doesn't have the classical phenotypic appearance of RP, but symptoms-wise and full field ERG-wise, it more or less looks similar at a cursory glance. But if you see, full field ERG gives certain characteristic features by which you can distinguish this enhanced S-cone syndrome from RP. You can see that these two are basically scotopic, and you see that the scotopic 0 decibel and the photopic 0 decibel are almost similar. And the characteristic electrophysiological finding in this case is that the 30 hertz flicker ERG amplitude normally is midway between the amplitudes of the photopic 0 decibel A and B waves, whereas here it is the only condition in which the photopic 30 hertz flicker amplitudes are lesser than even the photopic 0 decibel A wave amplitude. And you can see that the S-cone activity is also quite high. Coming to cone and cone rod dystrophies, I'll not go into the clinical characteristics. I'll just show you the ERG pictures for want of time. This is a cone dystrophy. You can see that the scotopic, this is a normal patient. This is the right and left eye of another patient. You see that the scotopic responses are more or less equal, but when you compare with the normal 30 hertz flicker and the photopic 0 decibel, you see that in this patient the 30 hertz flicker is subnormal amplitude as well as delayed, as well as the photopic 0 decibel is a very poor cousin when compared to the normal patient. Then ERG also is able to give us an indication of the type of cone dystrophy. Most of us don't have access to genetic counseling and genetic studies. Whereas if there is an amplitude reduction without an implicit time shift, you're most probably looking at autosomal dominant type of cone dystrophy. Whereas if there is both a delay as well as an amplitude reduction in 30 hertz flicker, you're looking at most probably autosomal dominant cone rod dystrophy. Then there are certain stationary cone dystrophies like rod and S cone monochromatism, which we commonly refer to as congenital achromatopsia. And in this, what is important is the photopic ERGs and the 30 hertz flicker will be totally flat. As you can see, these patients present from childhood and usually are confused with cone dystrophy, whereas in rod and S-cone monochromatism, the photopic responses are undetectable. Rod responses are pretty good, and even if they are subnormal, following dark adaptation, they pick up quite well. So So again, as I already told you, again to answer this gentleman's question, full field ERG basically is of pan-retinal origin. So why should you do ERG in macular dystrophies? Macular dystrophies, you feel that full field ERG has no role. But in certain type of macular dystrophies like Stargardt's fundus flavimaculatus, bullseye maculopathy, which is a loosely grouped condition characterized with having so many disorders, having the bullseye picture in the macula, as well as in BESS, we should do a full field ERG. Coming to Stargardt's. Basically, it's a very elegant study by Louis et al., which has divided patients with Stargardt's into 3 subgroups. Group 1 has normal full field ERG, Group 2 has additional generalized cone involvement, and Group 3 has cone and rod system involvement. So what happens in Stargardt's, this is a very important message. Presence of a normal ERG at any stage during the course of the disorder is a very good prognostic indicator for retention of peripheral retinal function. So it's a very important information that you can give to your patients. And the electrophysiological abnormalities are 100% concordant across sibling pairs. And in group 3, as the duration of the disease increases, the severity of the electrophysiological abnormalities increases, and so does the severity of functional loss. So this is an example of Stargardt's fundus flavimaculatus. As you can see, the ERG full field ERG is almost normal, but the pattern ERG is extinguished in keeping with the pure macular dysfunction. So this is group 1. So these patients have a very good prognosis for retention of peripheral retinal function. So bullseye maculopathy, you have 4 types: macular dystrophy, cone rod dystrophy, and rod cone dystrophy. Commonest is macular dystrophy. But what is important is you have a patient with macular dystrophy, you get with the bullseye maculopathy, and you get a normal ERG. It doesn't mean that the patient is having a good prognosis for retention of peripheral retinal function, unlike Stargardt's. The pattern keeps varying. So that's an important point as well. Then usually when the EOG is abnormal, you will have an abnormal ERG. In contrast to BESS disease, where there is a normality of a full field ERG, as in this patient. You see the EOG of right and left eye of this patient absolutely flat, there's no light rise, and the ERG is absolutely normal. So then, few more indications why you should do a full field ERG. Diseases of the inner retina can have a normal or a very confusing fundus appearance, and you can also distinguish between stationary and progressive types of night blindness. I will be dealing with all the types of night blindness in my next talk on electrophysiology in children, where I'll show you the ERG pictures as well. And then coming to ERG in acquired retinopathies in CRVO, as Here would tell you, he's a very grand advocate of central retinal vein occlusion and ERG in that. The B by A ratio, if you would remember, B by A ratio is usually positive, but if the initial negativity of the B by A ratio suggests that it's an ischemic CRVO that we are looking at, and the progressive improvement or deterioration with time reflects the way CRVO is going, whether it's becoming more ischemic or becoming more non-ischemic. Similarly, another thing which you should look at is the 30 Hertz flicker interocular amplitude. If there's a difference more than 23 microvolts, the patient has a very high risk of neovascularization, and the ratio, that is ratio is more than 60%, again, very high risk of neovascularization. Now this picture looks like an ischemic CRVO, doesn't it? But if you look at this is a normal patient. This is a normal patient, this is right and left eye of the patient with this problem, and you see that there is not much of difference in the 30 Hertz flicker. At the same time, the B by A ratios are not negative. So this patient has only a non-ischemic CRVO, though the fundus appearance might tempt you to think of something else. And in autoimmune retinopathies like carcinoma-associated retinopathy, where ERG is going to be totally flat like RP, or melanoma-associated retinopathy, where you get a negative ERG. Okay? These are the other conditions in which ERG helps. And Azure, it's basically acute zonal occult outer retinopathy. It's a poorly defined condition characterized by photopsia and visual field loss in the presence of relatively mild fundus changes. And the ERG markers are basically delayed EOG light rise and a decreased, delayed 30 Hertz flicker. This was one of the patients which I picked up in Moorfields Eye Hospital Electrophysiology Lab. You see that the left eye of this patient, the EOG light rise is lesser when compared to the right eye, and you see that the 30 Hertz flicker in the left eye is also delayed and subnormal when compared to the right eye. So this patient actually had Azure. And when you are suspecting an intraocular foreign body also, you see that the ERG parameters are very much reduced. You can get even a negative ERG. And so the bottom line, these are the several clinical applications of ERG for RP, inflammatory conditions, autoimmune retinopathies, helps us to identify suitable patients for therapy as well as patients who would benefit from genetic counseling, and helps us to manage diabetic retinopathy and CRVOs, and helps to monitor the retinal toxicity of drugs like hydroxychloroquine or plaquenil, cisplatin, vigabatrin, which is being increasingly used nowadays in epilepsy, and efficacy of treatment as in Refsum's disease, and the latest most promising gene therapy as well, and also helps to prognosticate ocular trauma, detached retina, whether to operate or not. If you get a recordable ERG, we should go ahead and operate. Thank you very much for your patient hearing.